Okay. So, good evening and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is a digital partner of this event organized by Oncology Integrated Society. And the topic of today's session is breast concerns, what an OBGYN should know. So let's begin today's session, for which I would like to hand over this session to Dr. Dipti Chaturvedi, ma'am. Over to you, ma'am. Please proceed with your talk.
Yes, first I would like to welcome all for the lamp lighting and Ganesh Vandana. Please play
Yes.
Ganesh Vandana.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Hello and welcome all to this yet another episode of Cancer Webinar Series. It is a matter of honor and proud privilege to host this webinar from the aegis of Oncology Integrated Research Foundation, Dr. Chaturvedi Cancer Hospital and ClearNet team. Today we have with us a very learned, talented, astounding and a brilliant speaker, Dr. Sneha Bhuyar, who has a record experience 32 years in this field and who will be talking, as has already been mentioned, breast concerns, what an OBGYN should know. Welcome, ma'am. We also welcome respected Professor HOD and Dean, KGMC Lucknow, a senior doctor with charms and elegance, full of knowledge and surgical skills to chair the session, and who has been my senior too from our alma mater, who is having a very high fever now today, but has still made it for the day, none other than Professor Uma Singh, a true fighter in a true sense, to chair the session. Welcome, ma'am. We also have another respectable lady full of wisdom and enigma, a timeless beauty and intelligence, who has also received a UP Ratna Award and who has been ex-professor HOD, women with superb strength and resilience. Who else but Professor Radha Jina, Senior Consultant, for chairing today's webinar. We also have Dr. A.K. Chaturvedi, the man behind this series and renowned oncologist, owner of Dr. Chaturvedi Cancer Hospital, with a record experience of treating cancers for about 40 years and who has been past president UPARI with extra trainings abroad, with many awards and publications to his uh, credit and to add extra feathers to his cap. Once again, I welcome all the dignitaries, participants, colleagues, friends, seniors, juniors, all the attendees to this webinar. Hope today's webinar bridges our lacunae and enlightens our knowledge to its best. Welcome, all of you. Questions will be put in the chat box so that they can be discussed at the end of the meet. Now I welcome Dr. A.K. Chaturvedi. I hand over the dial stream. He'll be introducing the chairpersons and the topic. Yes, Dr. Chaturvedi.
Thank you, Dr. Deepthi. Today's topic is very important. As you know, more than 25% of women are affected with breast disease during her lifetime. And the lump in the breast, they are mostly non-malignant. Only 10 to 20% they are malignant. So our concern is how to deal with such type of lumps and what should be the role of obs and gynecs. Because most 50% of the population, that means most of the ladies, they are going to gynecologists and they are the first person who will notice this type of disease. So the vast majority of these type of lumps complains of a new breast lump. Fortunately, most of these are benign. 60 to 80% of breast lumps are non-cancerous. As I just said, benign breast conditions are very common and not life-threatening. But some benign breast conditions are just like fibroadenomas, papillomas, cystodenomas, hemangiomas, hematomas, adenomas, neurofibromas, and others. Risk factor is 40% higher in premenopausal women.
तो आप सारे टॉपिक
The postmenopausal. Can you hear me?
Yeah.
Okay.
Audible.
And the overall percentage of developing carcinoma is 156.6 cases per 100,000 females worldwide. So breast cancer risk increased 3% from the post-menopausal time. Means menopause when it starts, it keeps on increasing the chances of malignancy. So now today, to discuss about this particular topic, we are having our respected head of departments, Dr. Radha Jina. She is DGO, MS, FICS, ICOG, ex-professor and obstetric and gynec, BRD Medical College, Gorakhpur. She has done her...
Dr. Chaturvedi, Deepthi has already introduced me.
Okay, but let me say, because
No
this
need.
I have come to know that you have graduated from MLN Medical College,
Yeah.
Allahabad. Yeah, this is important. And she is retired professor from BRD Medical College, more than 100 papers. She has attended almost all the UP conferences, national conferences, gynec and few internationals. Past president, GOGS, president of UP's COG, 15 to 2017, organizing chairperson of UP COG 2016. She is felicitated by IMA Gorakhpur, Navdurga Award by the Rotary Club, Amar Ujala by 2019, Chief Patron of Vaccine Saving Mothers Conference 2019, Patron of CEFOG Gorakhpur Branch, Gorakhpur Ops and Gynae Society. She was awarded by UP Ratan in January 2022. Awarded ICOG. After retirement, she is still serving the humanity actively. She's a very active lady of Gorakhpur. Next, our chairperson is Professor Uma Singh. She is Senior Technical Director, University of Manitoba, ISAT, UPTSU, ex-head of department and dean. I don't say ex, but former head of department and dean, KGMU, Lucknow.
Better.
WHO fellow in gynec oncology, fellow in Indian medical education, president of UP chapter of Association of Gynec Oncologists of India 2019 and 21, vice president of AGOI 2017 and 2019, governing council member of ISCCP, nodal officer for cervical screening program of UP government NHM. Master trainer for EMOC, postpartum IUCD, PPS, lab ligation, etc., etc. So she has got so many things to her credit. Now I welcome both of you and please take over the seat and introduce Dr. Bhuyar for a lecture. I request Dr. Jina or
Thank you, Dr. Chaturvedi, for your nice introduction. Good evening, everyone. It's my pleasure to introduce very pleasant and humble Dr. Sneha Bhuyar, who is Managing Director, Sukhkarta Hospital, Maternity Nursing Home and Fertility Center. And she has a huge experience of 32 years. She has National Adolescent Trainer WHO FPAI certified, a national expert UNICEF, peer reviewer of JOGI, IMA Maharashtra State Chairperson and MPH Committee, and convener of PCPNDT. AMOX Chairperson Medical Disorders Committee from 22 to 24, and AMOX Chairperson Emergency Obstetrics from 24 to 26. CEPHOG Working Group Member on Breastfeeding, and Founder President ISOPAV Vidarbha Committee. Now, she has SN many awards to her credit. She has SN Malhotra Unsung Hero National Individual Award for Outstanding Work in Rural Obstetrics 2008. Dr. Duru Shah Distinguished Community Service Award 2022, and Champions of Foxy for 2 consecutive years, and Dhira Award. She was awarded twice by Government of Maharashtra at the hands of Governor of Maharashtra. She has many articles and chapters in national publications, and about 300 of talks and orations and keynotes in different conferences. Now today she will be going to speak on what an OB-GYN should know about the breast. We know that every obstetrician should be aware of breast, its anatomy, physiology, and in detail, we should know how to examine the breast. Because we know most of the young girls and ladies, they come to obstetrician and gynecologists first if they have any problem in their breast. And we are the first one to examine them. So we should ourselves be very much aware how to examine a breast and what is normal and what is abnormal. If we find any lump in the breast, then we should be able to differentiate whether it is a benign lump or it may be a malignant lump. So we should ourselves be aware of these facts, and if we find that there is nothing in the breast and there is no lump, the patient is very much anxious about the breast, then we should ask her how to examine her lump herself, and periodically she should examine her lump, and if she finds anything problematic or abnormal, then she should again come to us. So with these words, I invite Dr. Sneha for your talks. So over to you, Dr. Sneha.
Thank you so much, madam. Thank you for that generous and a very kind introduction. First of all, let me thank the dynamic couple, Dr. K. Chaturvedi and Dr. Dipti Chaturvedi, and of course the chairperson, Dr. Madam Radha Jina and Madam Uma Singh.
Thank you, dear.
We just, meanwhile, I'll just start sharing my presentation. So I hope you can see it, and I'm just making it full screen. So thank you so much for this, taking up this topic, because I'm sure as committee chairperson, my introduction for majority of you, I was a past committee chairperson of breast committee of FOXY for almost 4 years. And in these 4 years, what we have done is we have tackled 3 issues, mainly the breastfeeding promotion, benign breast diseases, and awareness and early detection of breast cancer. Now, why you will say, why should we do all this? You know, we have been sending our patients to surgeon. So friends, basically, breast is our domain. As far as, you know, the breastfeeding promotion and the problems associated are concerned, as far as the benign breast diseases are concerned, even, you know, any lump in the breast is concerned, the women are comfortable with their obstetrician gynecologist, and they go to the obstetrician gynecologist first, and that is why we should utilize this window of opportunity. And by virtue of our practice, all of us are well versed with all these problems, so definitely we can tackle this better. So for this, actually, we have to revisit this aspect, and we have to sensitize Foxians by organizing various academic sessions, CMAs, publishing e-newsletters, updates and ready reckoners, training the paramedics for clinical breast examination, to teach the common people the self breast examination. And of course, for common people, we had organized many awareness sessions and mass screening programs, because all of you know that early detection makes all the difference. Friends, the breast has always been, considered as the symbol of womanhood and ultimate fertility. And so either the disease, both, I would say, the disease or the surgery, both evoke the fear of mutilation and loss of femininity. And that is why all of us have gathered here to know exactly how to diagnose the breast condition and how to tackle with it. So I will go ahead with the breast examination last purposefully, because I suppose that all of you know the breast anatomy, physiology very well. And estrogen and progesterone, these are the feminine hormones which are responsible for the feminine development of the breast. And these are the same hormones which are responsible for the breast cancer. So we start with the simple non-malignant lumps in the breast. So you have, I just try to make it very simple through the simple case scenarios. You have this 20-year-old girl who has come to your clinic with a complaint of painless lump in the right breast. Maybe she just noticed it few months back, and when you examine, you find that it is a well circumscribed rounded lump of about 2 by 2 centimeter, firm in consistency, non-tender, freely mobile. It is neither adherent to the skin or the underlying structure. So what is your diagnosis? Do you need any other investigation to confirm the diagnosis? What is the treatment for this patient, this young girl with small lump, and does it affect or does it differ according to the age group of the patient? So basically, of course, considering the characters, I'm sure all of you got or spotted the diagnosis. It's a benign breast lump, that is the fibroadenoma, which is the most common lump, and it is nothing but the stromal and epithelial proliferation arising from the terminal ductlobular unit. So basically, this is a benign tumor. Malignant transformation is very rare. So what you need to do is confirmation of the diagnosis, rule out malignancy, and reassurance. Now, when do you need to remove these tumors? So basically, when you have a giant fibroadenoma, a complex fibroadenoma, will come to it. What is complex fibroadenoma? Suppose fibroadenomas persist after 35 years of age, or there is a family history of breast cancer. So all these conditions, they necessitate the excision. You have small fibroadenomas, juvenile giant fibroadenomas, benign phyllodes, and malignant phyllodes. These are the different types of these fibroadenomas. So why you need to go for ultrasonography? For this young girl, small swelling, ideally, I mean, actually, there is no need practically, but yeah, the parents are anxious, the girl is anxious, and you also want to be safe. So maybe ultrasonography is the only investigation you may have to just go for documentation and confirmation. So this is a very typical picture where you can see the solid swelling, the echogenicity, and the well encapsulated swelling. So once you confirm this diagnosis, you have to just look for the management. How do you go ahead? Now, this is only 2 by 2 centimeter, young girl. Ideally, there's no need for excision. Reassurance is the treatment. So when do you need to do the excision of this lump? If the swelling is more than 5 centimeter, then you have to go for excision. If it is, as I said, fibroadenomas persisting after 35 years of age, family history of breast cancer, and complex fibroadenomas and giant fibroadenomas. Giant fibroadenomas, definitely, maybe we say benign phyllodes, and the size is also more, and there are multiple, bosselated type of swelling. Complex fibroadenomas, where, it harbors epithelial calcification, apocrine metaplasia, and sclerosing adenosis. So these are the three criteria which the cell, the lump, it necessitates excision. Coming to the next case, you have this 35-year-old young lady. She comes to you with pain in both the breasts. Every time she gets menses, just before the menses, she gets lumpish feeling and she complains of pain. When you examine, you find that there is rice grain nodularity all over, tenderness, but there is no definite lump as such. Maybe there is little thickening at the upper and outer quadrant. What is the diagnosis? Does it need further investigation? And what is the treatment for this patient? Very classical picture, history, fibroadenosis or fibrocystic breast disease, benign, what you say, call it as premenstrual mastalgia. So these are the different names for this condition. Why does this arise? This is because of the imbalance between the estrogen and progesterone. And of course, it worsens with certain food components and premenstrually. Do you need the investigations? Actually, no. But yes, once again, just to be on the safer side, and if the woman is above 35 years, you have to go for ultrasonography. And if at all you find a large cyst, maybe you just go for FNSC for confirmation, FNSC and cytology, and then you confirm that there is no risk of malignant transformation. Previously, we used to think that this is purely benign condition, but yes, recently it says that 1.5 to 3% chance for malignant transformation. Though this is quite less, I mean, you should not take any risk. And if at all you find the elderly lady with this kind of cystic swelling, definitely you should subject her to FNSC. Atypical lobular or ductal hyperplasia and lobular carcinoma in situ, these are the conditions to be worried. So how do you manage? This has got a specific management and a general management. So you have to cut down on caffeine, tea, coffee, soda, energy drink. Of course, you have to lower the added sugars, restrict your fat intake from the diet and increase your fiber intake. Eat lots of fruits, vegetables, whole grains. And then, of course, local treatment, hot fomentation, support to the breast, maybe just local NSAID gel application or oral NSAIDs. Decrease your estrogen intake, that, OC pills, some people, if they're taking. But vitamin E, evening primrose oil, GLA, and fish oil, I'm sure majority of us are using it. Though there's no definite evidence, we are getting good results and all of us are using it. The definite treatment and very successfully what we have found is SERM, selective estrogen receptor modulators. Orbiloxifene is the one nowadays we are using, which is very, very good. It gives fantastic results for 3 months, maybe twice a week. If you give it over 12 weeks, then it gives you good result. Danazol and tamoxifen are to be, not to be used unless it's a very severe intractable pain where all other measures have failed. Now, suppose you find a large cyst for such patient, and this is the ultrasound picture, then of course you have to think about what should be the management. Now, if it is a simple cyst and if it is painless, we don't have to touch it. But if it is tense and tender and painful to the patient, then you have to aspirate and relieve her of the symptoms. Of course, you send this for cytology. If it's a galactosile, usually it disappears when the lactation stops or breastfeeding stops. If it is not infected, in fact, better not to touch it. But if it is infected, then you have to go for aspiration. Now, this is one more case. You can see, the large engorged breast. This is a lady who is delivered 5 days back. She comes to you with feverish feeling, body ache, overfilled, tense breast, shiny nipple, very painful. And when you try to, look for the milk secretions, there's no milk flow. Diagnosis is very obvious. It is engorgement of the breast. And why this has happened? This is not, milk is not flowing doesn't mean that there is no milk. It is in fact lots of milk which is, trapped inside. And why this has happened? This is because of the delay in starting to breastfeed. So early initiation is the treatment. How early? The moment the baby is delivered, you have to put the baby to breast. Government of India initiative, what is called as MA, that is Mother's Absolute Affection. It recommends the baby to be delivered on the mother's abdomen, and even before cutting the cord, the baby should be put to breast. Maybe even if you just leave the baby, it crawls towards the breast. That is called as breast crawl. How to attach this baby to the breast, that is very, very important. You don't have to just give the nipple to the baby's mouth, but in fact a very good attachment. That means nipple and part of the areola should go inside. Then only the pumping or the sucking becomes effective. Infrequent removal of milk. Sometimes the mother is very sick, tired or operated. Sometimes the baby is sick or shifted to ICU. That is a condition where you get this engorgement. So frequent removal of the milk manually or with breast pump if the baby is not feeding. Restriction of the length of feeds is also one. Some people have the myths that feed for 10 minutes, 5 minutes. So unrestricted, complete breastfeeding, that is what is the ideal situation or instruction. You can see here in the picture, nipple and the part of the areola. If that goes inside, that is a good attachment. Now, some people have the myths that if you have a flat nipple or a retracted nipple, the woman cannot feed the baby, breastfeed the baby. Even if you antenatally diagnose it, you are not supposed to. Some people say manual correction. No, near term, maybe during 9th month towards just before labor, you may have to just try and squeeze it at the areola. See if that is retracting still further. Then that is a truly retracted nipple. Otherwise, if you just squeeze the areola and if it protrudes, that is not a true retracted nipple. Near the term, definitely you can manually correct it. Otherwise, before term, if you try to do it, nipple stimulation may cause contraction. So that is again not advisable. So do not rest the breast. If the baby is not suckling at the breast, if the baby is not with the mother, you express the milk. Now for this patient, she's very, she is in agony. So you have to stimulate oxytocin. Relax the mother. First, and all of you know that pain, worry, doubts, all these are, they hamper the oxytocin reflex. So relax the mother, massage her back and neck, light breast massage, stimulate the nipple, and give either warm shower or warm compresses, and then gradually start feeding the baby with good attachment. At the end of breastfeeding, give her cold compression, maybe like this, the cabbage leaves. If at all the baby doesn't see, you don't have to immediately squeeze the breast, but these are the steps where you have to massage, and with 4 fingers below, thumb above like this, you have to gently squeeze the breast. If she cannot do this with her own hand, maybe we can use these types of pumps, which can be manual or battery operated or electric pumps. Now, this is just the addition. How should what position the mother should feed the baby? Cradle hold, cross cradle hold, football hold, Australian hold, and sideline. Previously, there was a myth that you should not feed the baby in sideline position. The baby may get asphyxiated, or the baby may aspirate. Nothing of this is a myth. Whatever position the mother and baby is comfortable, the mother can feed the baby. That is what is the moral of the story. Just to have though this is not related to this topic, I would just tell you about the good breastfeeding techniques. The mother should wear comfortable apparel and she should be able to expose herself to the baby. Her breast should be well exposed. The baby should lie in a good position, neutral position. It should not the baby lying in supine position. You are trying to turtle the neck sideways. So it should not be that. The baby should be comfortable, well supported so that it can latch comfortably. The baby is brought to the breast with nose touching or close to the breast, and the gum line should overlap the areola. As I have said, the nipple and part of the areola should go inside so that the tongue moves forward beyond the lower gum and forms a cup. And of course, there is a negative pressure that pumps out the breast milk from the breast. Now coming to the next case. Here you have 25-year-old woman, para 1, who has undergone cesarean section 2 days back, and she complains of fever, painful lump in left breast, severe throbbing pain. Right breast is also painful, but when you examine, you find that she's febrile, tachycardia, BP is normal. Right breast is engorged, but there is no lump. Left breast is engorged. There is a 6 by 6 centimeter lump, which is tender, hot, and fluctuating. I'm sure you got the diagnosis. This is a very clear-cut case of left-sided breast abscess. Now, how do you manage this case? pus anywhere in the body has to be drained out. But whether you drain it with incision and drainage or you drain it with aspiration, that is now a matter of debate. We have been doing this aspiration over now almost 5 to 6 years, and it's giving fantastic results. So for this patient, antibiotics, anti-inflammatory, regular breast massage, expression or baby feeding the baby has to continue. If you stop breastfeeding, the problems will worsen. Now, if you have a smaller breast abscess, you can, aspirate the abscess with 14 to 16 gauge needle with or without local anesthesia very easily at the single sitting. But such large abscess, 6 by 6, it is little difficult, and maybe you may need 3 to 4 sessions of aspiration. If at all it is a deep-seated abscess, you can go for ultrasound guided aspiration. What Cochrane says, previously, I'm sure all of you must have witnessed this, that, whenever we had these patients of breast abscess, we used to send these patients to surgeons, and they will go for incision and drainage and leave a large cavity to be healed by, secondary intention. And daily you have to pack the cavity, do the dressings, and things have become so messy that you don't feel like feeding the baby. The mother also doesn't want to do this because it becomes so painful. But nowadays, because of aspiration, this has definitely become very advantageous. What Cochrane has given, that there are almost 4 studies of 325 women. They say that both the methods, they are equally effective at present, because there are, it needs further studies to come to the conclusion that which one is superior over the other. But definitely, aspiration is a very effective, needle aspiration is a very effective way of, treating the breast abscess as well. With the breast abscess, whether the mother can feed the baby, yes, definitely the mother can continue to breastfeed, because, and what are the advantages? She doesn't need anesthesia, doesn't need surgery, there's no incision, there's no pus draining out, and she doesn't get pain because of daily dressings and packings, and you can easily continue with the breastfeeding. And that is why needle aspiration is a very, very effective way. Few of our members, I have been doing this routinely since I think last 8 to 10 years. Some of our members are doing this, and they have the studies of nearly 100 cases. So all of them are, going ahead with needle aspiration. Now, going to the next case, we have 32-year-old nulliparous woman. She notices a small lump in the left breast just a month ago. It is painless. When you examine, you find that there is a vague lump, 2 by 2 centimeter in outline, irregular, non-tender, hard in consistency. There's no nipple discharge and no axillary lymph nodes. Right breast was normal. The diagnosis is very obvious. It is probably breast cancer, but yes, you have to follow the triple algorithm: the history and clinical examination, imaging, and then the tissue diagnosis or tissue biopsy. So here you have to submit this patient to investigation, so sonomammography or mammography, and then of course a true cut biopsy. For a cystic lesion, you have to go for FNSC. For a solid lesion, you must go for true cut or core biopsy. MRI, if only these two are inconclusive. Now, young lady, nulliparous with early breast cancer. So definitely surgery, that is of course a definitive management, but whether you should go for a radical surgery or conservative surgery along with radiotherapy. Young lady, nulliparous, early breast cancer, definitely you have a scope for conservative breast surgery, but of course it has to be followed by or accompanied by radiotherapy. And once you remove this tissue, you have to send this for histopathological examination, ER/PR, and HER2. And then accordingly, you have to go for postoperative management, whether it is hormone therapy, chemotherapy, or Herceptin. Now, for this young lady, is it only the removal of that particular lump, that is breast conservative surgery, or oncoplasty? So what is oncoplasty? Oncoplasty is a conservative surgery for early breast cancer, which actually follows the principles of both a good oncological control along with the cosmesis. So it has to, you have to see to it that the long-term prognosis is good, the disease-free period, the quality of life following the surgery is good. So you have to tackle this situation very, very effectively, and you have to decide, evaluate this patient very thoroughly before going for any conservative surgery. So these are the various types of oncoplastic surgeries. I will not go into the details of this, but just coming to the last case now, we have this 25-year-old young lady who delivered 2 months back, and she comes to you with, some burning sensation, pricking sensation in her right breast. When you examine, you find that the breast is so red, swollen, tender, edematous, and where the surrounding skin is like, showing the body orange appearance. Nipple, they are is slightly retracted. There's no localized lump. It's like insect bite, like itching. She gets stinging sensation. She gives a history of antibiotics, anti-inflammatory for last 2-3 weeks, and she has changed 2 doctors. But there is no relief. So what is the differential diagnosis? I'm sure initially you will feel that this is a case of mastitis, but the very fact that the lady with mastitis who doesn't respond to antibiotics, anti-inflammatory, she has changed her doctor, changed her antibiotics, still she is not getting the response. Think of inflammatory breast cancer. So which investigations to confirm? MRI is in fact the investigation, and of course the skin biopsy, because this is a lesion, this is a disease which presents with skin involvement. Skin is the first thing to be involved, so that when you diagnose it, it's already stage 3 and beyond. So this actually inflammatory breast cancer is a disease of young women. It is a very, very aggressive cancer, as it grows very quickly, and the moment it is diagnosed, it's already advanced. It is stage 3 and beyond. So this is a worst cancer, I would say. The outcome is generally not as good as it is for the other types of breast cancer. Survival rates can give you an idea of what percentage of people with the same type of stage cancer are still alive at a certain amount of time, that is 5 year survival rate. And after their IBC has a very poor 5 year survival rate as compared to other types of malignancy. Definitely, the lady being young, you have to think of, the very radical surgery, because this is a very, very aggressive tumor, and biopsy and further management, as we have already discussed. I'm sure the oncosurgeons and oncologists, they will comment on this. These are the certain aspects which we obstetricians have to think, that whether this lady can breastfeed after the cancer treatment. There's no question of transferring the malignancy to the baby. Definitely she can breastfeed, unless she's on some radioactive isotopes. So if the opposite breast is unaffected, we can continue to breastfeed. Breast cancer survivor who has received tamoxifen, they really need to be followed up very, very carefully, because this is a drug which leads to, endometrial hyperplasia, and which can, the lady can land up into endometrial malignancy. So for her, you need to go for, for this treatment, she has to continue at least for 2 years. So after completion of 2 years, after completion of the treatment, then only she can think of something else. By the time you have to prescribe her some effective contraception, and that can be progesterone only pills or LNG IUS, which is the long acting contraception, progesterone only, not the estrogen. So that is how we have to have this, as obstetrician gynecologist, what message I would say, that, the women are comfortable with the gynecologist, and for whatever problems they have, they come to us. So whenever the lady comes to you, you have to, in addition to her other problems for what she has come to, you must go for all this inquiry. You have to go for breast screening, and this screening consists of three parts mainly, that is the risk screening, breast screening, and genetic screening. So what are the risk factors she has? So you have certain modifiable factors which you can actually work on. So obesity, alcohol, her age at first child, breastfeeding practices, combined OC pills, and menopausal hormone therapy. These are the factors which you can modify. But there are certain factors like you are a woman, so you have very high risk for having a breast cancer. Your advancing age will add to the risk, and of course, family history definitely will increase your risk for breast cancer. Your personal history, that means if you have had CA breast for one side, you have a very high chance of having a breast cancer on the opposite breast, not as recurrence or secondaries, but even independent second, what we call it as multicentric malignancy. Early menarche menopause, that is wider exposure to estrogen, increased breast density, chest irradiation during childhood, and BRCA1 and BRCA2 mutation positive. These are the risk factors which actually they are non-modifiable. So what do we have in our hand? The self for our resource poor country like India, having breast awareness, women are not even, see, they have some problem, then only they will go to the doctor. But if at all you make them aware of their breast, they will at least look for it on their own, what is called as self breast examination, which they should ideally start from 20 years of age. They should do it every monthly in the post-menstrual phase. And how they should do, you can see the picture. She has to stand in front of the mirror, expose herself completely, or maybe when she is having her shower, she with her right hand she can examine her left breast, and with the left hand she can examine her right breast. But for this self breast examination, you have three phases: the inspection and palpation, definitely. So inspection, she has to stand in front of the mirror, expose herself with the arms hanging by the side first, then raised above the hand, and then thirdly on the hip and bending little forward. So she has to look for various abnormalities like um, the symmetry of the breast, the size of the breast and symmetry of the breast, any lumps or bumps, what you can see, either some lumps or maybe puckering or dimple, discoloration of the skin, maybe scaling of the skin, all these things she has to look for. So on her own, she has to do this. So that is inspection, followed by palpation. As I have said, even while standing position, she can do it, right hand used for the left breast and left hand for the right breast. Then, of course, as breast, she has to examine from upside down or side to side, and also the axilla, armpit on both the sides. That everything she has to examine. So if she finds any abnormalities, she has to report to her gynecologist or her family physician. If at all she doesn't find any abnormality, she should continue to do this, and yearly she has to go for what is called as clinical breast examination. So the similar way, inspection and palpation, if it is done by a clinician without using any gadget, then we call this as clinical breast examination, and this has to be done every yearly. Of course, for an average risk woman, we'll see what is high risk and what is average risk. So regular clinical breast examination should start from the age of 30 years for an average risk woman. This is what we have seen. What investigation they should do regularly? Ultrasound. See, if the lady is young, before the age of 40, she should go for ultrasonography, because this helps you in identifying the lesion, even if it is in the depth. It will differentiate the morphology, whether solid or cystic. If at all you need to take any biopsy, guided biopsy, it can be done. So for a young girl or young lady before 40 years, ultrasonography is the ideal investigation. 40 years onwards, you have to go for mammography. Now, there are so many associations we have, which, they are advising on the they're advising the screening strategies, but all of them unanimously say that for an average risk woman, before 40 years, you don't need to go for any screening procedure. But yes, you must offer them screening 40 to 44 years of age. But 45 years onwards, you should make it mandatory annually. That is what is American Cancer Society guidelines. I'm sure for India, if everything is normal at the first mammography, maybe every 2 to 3 yearly we can go ahead with mammography. So 45 to 54, if things are normal, there's no abnormality detected, we can taper it down to this every 2 yearly, and we can discontinue screening when the life expectancy is less than 10 years. So that is how the screening strategy. I'm sure BRADs, all these different images, I will not go into the details of this, but then MRI, yes. MRI is not the primary investigation or screening tool. In fact, when both ultrasonography and mammography is inconclusive, then only we should go for MRI in an average risk woman. Of course, for a high risk woman, every 6 monthly, we should subject the patient to for breast MRI. And when should we start screening for the high risk woman? At least 5 years earlier to the age of her relative at which she was diagnosed to have malignancy. So that is what is the screening initiation. What are the different types of biopsy? I've already said for cystic lesion, FNSC, for solid lesion, true cut or core biopsy. If the lump is small, of course, excision biopsy, lumpectomy, sometimes stereotactic biopsy, that is the one which we do at mammography. So these are the different guidelines. What is most popularly followed is American Cancer Society guidelines. What we have already talked about, self-breast examination and breast clinical examination every 3 yearly, mammography annually for an average risk woman, for high risk woman, mammography annually and MRI as well, but starting either from the age of 30 years or 5 years earlier to the age of diagnosis of her relative, that is the index case. So I would just say that we gynecologists are the privileged one. All these women, they come to us because they find themselves comfortable with us. So for whatever reason they come to us, we should utilize this window of opportunity and examine their breast. If at all you find any abnormality, you should subject them for further investigations. If at all you don't find any abnormality, you take this opportunity to teach her self-breast examination and tell her that she should do this at her home, and if at all she finds any abnormality, she should report to the doctor. So even though Western countries say that the evidence doesn't support that the self-examination reduces the number of mortality associated with or deaths associated with breast cancer, I'm sure in a resource-poor country like India, making the women aware of their breast, at least something is better than nothing. I think that is what is the principle here. Because if we can diagnose the disease early and treat them promptly, we can reduce the mortality. We can not only save the life of the woman, but we can also save the breast of the woman, and then of course the quality of life what is remaining for her. With this, I thank all of you once again, and if at all there are any questions, I'll be happy to answer them.
Thank you so much, Dr. Sneha. It was an excellent talk, and you have covered each and every problem of the breast. Now, in the young girls, if there is a lump less than 20 years, less than 2 centimeter, then I think we need not to worry it, just we have to follow it. But if it is bigger than 5 centimeter, then we have to do a aspiration biopsy, and if possible, then we can go for lumpectomy. Now, after the delivery, most of the time we find that because of either not proper breastfeeding or retracted nipple, very common problem patient come with is the mastitis and the breast abscess. Now, if it is an initial phase mastitis, we can go for antibiotic, anti-inflammatory, and most of the time it becomes normal. But if really it has made an abscess, then till now we used to just advise that it is incision and drainage. And
Yes.
you very nicely explained that no, it can be done by repeated aspiration with a white bore needle. So it is, I think, a new thing for me and many of us. So it is a very, I can say, patient-friendly treatment, and there is no need to have a surgery where she has to go for repeated dressings, and she can get pain, and every time with dressing she gets pain. Then there is one more common thing, it is a fibroblastic breast disease. Now, fibrocystic breast disease is also very common, and most of the patients come to us that there is a pain in the premenstrual phase of the breast, and we examine, there is nothing. But sometimes there is a lumpy feeling, which indicate that yes, there is a fibrocystic breast disease. And usually it does not need any treatment except the symptomatic treatment, which we can give for pain and some heat. You can say sometimes we can just say you can go for a mild this treatment. Otherwise, it doesn't need any treatment. Most of the time, we find that the patient is coming with the prescription of just tamoxifen and more so with dinazole, very commonly given by most of the private practitioner. So in a young girl, we know that we should not give dinazole. It may cause so many problems to her, like postmenopausal symptoms and so many problems. So it should not be given at all. If needed, then we can go for other better treatments. Then if the patient comes up, elderly patient comes up with lump, and then we have no suspicion of malignancy by examination, then well and good, we can advise excision and then active treatment if any needed. But if it is a malignant one, then we should immediately ask this patient to have either a core biopsy or cut biopsy. Cut biopsy, I think it should be diagnosed and confirmed with cut biopsy. And if it is malignancy and she is young, then we can go for conservative mastectomy, and then we can give radiotherapy and chemotherapy if needed. And if an elderly patient, then we can go for radical mastectomy followed by radiotherapy or chemotherapy. So I think you have covered each and every aspect of the breast disease. And one thing which you have very nicely covered, that we should tell every young woman to examine her breast herself on monthly basis or sometime 2 or 3 monthly, and how to examine, we should all explain to them and they can do it very nicely. And if any suspicion of any tumor or any other problem, then they can come and consult us. So thank you so much, Dr. Sneha, for your excellent talk.
Thank you, madam. Thank you so much.
Uma, would you like to say something? I think she's muted.
Yeah.
She's muted.
Most of the patients, they are coming to us.
I'll just unmute myself. Yes. Thank you so much, Dr. Sneha. There is no doubt about it that your expertise with that long 4 years of experience as chairperson of breast committee, there's no doubt about it, the kind of work you did in all societies we remember. I particularly like 2 points apart from what Dr. Radha Jina mentioned. One was every gynecologist must use the opportunity of doing a clinical breast examination of a woman, because we all know that apart from self breast examination, what is more important is clinical breast examination by any health care provider. So that opportunity should be used by every gynecologist. And also that entity which you pointed out, the inflammatory breast cancer, This is true, very often from one doctor to another, with the change in antibiotic, one more generation higher, the women get, delay in the diagnosis. So this they must be made aware of, and gynecologists particularly should be aware of. Dr. Sneha, thank you so much. I think you have covered the full spectrum and done it so efficiently, so nicely. It was a pleasure to hear. Even though I'm not greatly well, but I heard every word of it. Thank you so much. Thank you, Deepti and Dr. Chaturvedi, for organizing this webinar and taking up this topic, particularly for the gynecologist. Thank you so much.
Thank you, Professor Uma Singh and Dr. Radha Jina. You have nicely commented on it. And what we people are getting is breast sepsis, which is not treated, as you just now said. People are going from this place to that place. Inflammatory breast disease and breast sepsis. So breast sepsis cases, by the time we receive, it is the milk has become very hard and difficult to aspirate. That's the biggest problem. Otherwise, we need to aspirate the things. And that was the last thing. Then we have to resort to IND. So this is one thing. Moreover, inflammatory breast disease is very dangerous, very, very dangerous and difficult to control. Rightly said. And one should be aware about it. Very, very dangerous thing to, because it is radio-resistant as well. Chemo works very, very in a very few cases. So this is the worst part. We have to tackle very carefully this type of thing. Thank you so much.
Radio-resistant and chemo-resistant.
Yeah. Very difficult to control because it is involving skin, no? So thank you very much for the nice chairmanship, and Dr. Bhuyar, you have explained everything. Thank you so much.
Great.
To Dr. Dean.
Are there any questions?
I would like to congratulate both of you for taking up this initiative, working so hard for the women's health, and, you are the pioneer in, I would say, the women's malignancies. I would say I'm watching you both since last 3-4 years.
Thank you so much. Thank you, ma'am. Thank you so much.
Thank you so much, Dr. Sneha. It's just a pebble in the ocean. We have to go far to explore more. And are there any questions, Clarinet team, from the participants? Hello. I think so. They are also not listening.
7, it's already 7, that's right.
So let's take your leave, and we'll see you again, once again, in the next webinar. All of you have done so well justice to the breast cancer talk, even the chairpersons and the speaker. It was a very elaborative, crisp, and informative talk. Yes, Dr. Chaturvedi, please end the webinar.
Thank you. Thank you so much.
Thank you so much once again. Thank you. Thank you, Madam.
Thank you all. Thank you.
Madam.
Expecting to attend all the webinars organized by us and take participation. Thank you so much.
Please be there. Okay, thanks.
Thank you. Thank you so much. Bye-bye.
लीव का कहाँ है? चलो ठीक।
So thank you so much, everyone. Thank you so much, everyone, for extending us the opportunity to host this session. So with this, I would like to conclude the session over here and looking forward to host you again. Thank you.